is Abdul. My name is Hanis. I'm from Faculty of Pharmacy, UiTM Punjab. And on behalf of my team, I'd like to present our study findings entitled Adherence to the A component, which is avoid stroke, component of the ABC pathway in patients with atrial fibrillation and adverse clinical outcomes. Now, the ABC pathway was introduced to improve the management of patients with atrial fibrillation, thus improving their outcome. Now, the A component stands for avoiding stroke, B, better symptoms management, and C, cardiovascular risk factor management. However, the adherence to the A component has not been widely studied, especially in the local population. Now, the ABC pathway has nicely come up with this figure outlining what the ABC pathway is. Now, A, avoiding stroke should be done with oral anticoagulation therapy in those patients who have a child mass score of more than 2 in women and more than 1 in men. Assess their bleeding risk, and of course, you choose your anticoagulation either with a BK or no. B stands for better symptoms management, and this can be done with rate or rhythm control. And C, your cardiovascular risk management. Now, for the purpose of this study, I'll be concentrating on the A component, which is the avoiding stroke. Therefore, the objective of our study is to look at the prevalence, the factors associated with adherence to the A component of the ABC pathway, and of course, subsequent adverse clinical outcome. Now, in terms of methodology, we included AF patients under a regular follow-up of 2 cardiology centers within June 2020 to December 2022 in this retrospective cohort study. So, all patients above 18 with an ECG confirmed diagnosis of AF and managed with either a VKA or a NOAC for at least 6 months before their starting date until December 2022 in 2 cardiology clinic or INR clinic were included. Those with AF and heart failure, diagnosed with mitral stenosis or have mechanical prosthetic valve, and those who receive VKA other than AF were excluded. Now, looking at the A component, what is defined by A adherence? Now, A adherence is defined as those who are receiving vitamin K antagonists and they have a good time in therapeutic range, defined as TR above 1065. If they are prescribed with NOAC, they are dosed appropriately according to the ESC guideline. And all dose should be given unless their creatinine clearance is less than 50, a reduction dose should be given for the for approximate and approximate can go up to 30 doses. So adverse clinical outcome is defined as stroke or TB, major bleeding, severe hospitalization, severe mortality, and all of these were combined into one composite outcome. Ethical approval was obtained from 2 of these centers and of course from MRAC MOH as well. Now this is our figure flow chart. So we have a list of AF patients from both centers, Serdang and Hospital ITM, for about 1,006. So from that list, we choose every second application, and we came out about 503. After excluding about 181 patients, our final cohort consisted of 322 AF patients, and these were treated with either VK or NOAC. So then we look at them along 2 years to see the adherence to the A component and of course the adverse clinical outcome as stated previously. Now, in terms of results, and I will do the discussion together with the results. The first bit is the prevalence of A adherence, which is very good. We have about 70.5% of patients adhere to the A component, meaning if they are on warfarin, their TTR is above 65, and they are dosed properly if they are given a NOAC. Now, comparing our studies to the previous studies, to the other studies, we included about 322 Malaysian population, and our definition of A adherence is a TTR above 65 if you're on VK and you are dosed appropriately with a NOAC. And this is similar to the other 2 studies here from ST Pastor and Pastori. which are from Spain and Italy, respectively. You can see our adherence rate is better than our two counterparts here. Now, the other studies by Bucci, Koziel, and Brompet, Bucci had a higher prevalence adherence to the A component, whereas Koziel also higher than ours, but Brompet slightly lower. Now, bear in mind, these studies, they had a lesser strict meaning of adherence to the A pathway. For their studies, as long as patients are being anticoagulated according to the CHAPA score, they are considered adhered to the A component. Whereas S, even if you are anticoagulated, but your TTR has to be above 65, and you have to be dosed appropriately with the NOAC therapy. Now, looking at the second bit, the second objective, as you can see, the mean age of our patient population is about 70 years of age. No difference between the two groups, adherent and non-adherent. Majority of patients have hypertension, half and half female and male population. They have hypertension, diabetes, dyslipidemia, and only about 18% of them had underlying stroke. As you can see, no difference in terms of their demographic characteristic, except their creatinine clearance. If you can see, those who are E adherents had a better creatinine clearance, 65 compared to those non-adherents. They had a lower HASPAT score, and they have a higher mean TTR, which makes sense, because a higher mean TTR means you are adhered to the A pathway. And of course, if you see the pattern of OAC prescription, a large proportion of them are prescribed the NOAC therapy, and they are adhered to the A pathway. And lastly, the prevalence of adverse clinical outcome. As you can see, we have very small number of outcomes along the 2 years, less than 10 for stroke, severe mortality, and all-cause mortality. We do have 17 cases of CV hospitalization and 11 major bleeds. And all in all, about 43 means. So, comparing our study to the rest, with Bucci, this is a study conducted in 5 Asian Pacific countries. They have a high number of patients, but a shorter follow-up. So our rate of event is slightly lower than them, because we followed, slightly higher than them, because we followed the patients slightly longer than them. Now, as a conclusion, I would like to say that in our study, we found optimal adherence to the A component of the ABC pathway. Those with good kidney function and good quality of anticoagulation control with warfarin, respectively, and more likely to prescribe with NOAC than those associated with A adherent. Now, adverse clinical outcome and minimal overlap, suggesting that good practices were implemented among AF patients in both cardiology centers. With that, thank you.